All right, good morning again. So I just thought I would kick off a little bit by going a little bit deeper into one area that I talked a little bit about in the keynote, which is this idea of the healthcare dollar and how we think about it. Typically, we think about it as a single dollar, and I have to admit more and more, I think about it as several dollars. One of them is this idea of what's called community benefit. And as I mentioned before, healthcare typically is a not-for-profit industry. There are some for-profit hospital systems and others, but typically if a hospital is a not-for-profit system, it is required to file with the IRS what it does for community benefit. It actually is publicly available. You can look at any on the IRS, ProPublica listed or others, look at the 990 forms is what they're called, and you can see what is listed around community benefit. What's been interesting is that there has been some petitioning of the IRS around where does housing fit in this. And so the American Hospital Association and the Catholic Hospital Association actually petitioned the IRS to clarify what investing in housing would do. Was it on the first part of the Schedule H of the 990s, or was it on the second part? Which I think just gives you a sense of the healthcare industry and how we are starting to think about this and wanting to get credit for this type of investing. The other side of community benefit is many states have a form of community benefit that's called determination of need. How many people have heard the term community benefit? All right, some. How many people have heard the term determination of need? All right, a couple. So what this concept is, so I joke a little bit, the hospital industry is in the real estate business. They typically have real estate committees. They do it all the time. They just are doing it for their hospital, right? They're buying land, they're developing land, they understand most of this stuff. And so typically when a hospital is building, say, a new office tower or a new bed tower, there typically is a tax on that. Typically in Massachusetts, it's 5% of the total cost. So for instance, Children's Hospital in Boston is building $1 billion new tower. It will need to put out $54 million over the next 10 years in community benefit related to its determination of need obligation. And so that is another really interesting pot of money that, again, it's real estate related, and yet could also have, if you think about what is a typical need in a community, affordable housing is really high on the list. And so those are kind of some of the ways in which, frankly, I've been engaging my hospital, Boston Medical Center. We also have determination of need obligations because we are rethinking our campus and building. And so therefore, those are dollars that are important. The second group of dollars is what I sometimes call the provider or insurance dollars. And again, we are engaging more and more what are called value-based contracts, where we are not being paid on a fee for service. The more service we do, the more fees we generate. We're being paid to deliver a value, and therefore typically that's a capitated rate. It's a lump sum. It's literally a per member per month fee that we get to us for every covered live that we have within our system. And so it's forcing us to think outside of the individual patient population and thinking across our total population. And so that's when I was talking about this population health pyramid and who's at the top that's using a lot of healthcare. It is also about that rising risk group, that group that's starting to utilize more. How do you help them? And then how do you keep people well? And so in that you have certain cross-subsidization. You have certain people that are well that aren't using a lot of their per member per month dollars, and then you have certain people that are super expensive that are like breaking the system in terms of how much money comes through. And so that's where you have good news, more flexible dollars. It's not tied to a service. The bad news is the healthcare industry is kind of got to rethink how it delivers care and thinking about new ways in which to allocate those dollars. The third piece is the investment dollar. That's the other thing that I kind of didn't know and learned is that, yeah, every hospital has an investment committee that it invests its endowment. And typically most academic, highbrow teaching hospitals particularly have huge investments. And so, again, may not be as publicly available, but that is where I sometimes will talk about doing your homework, where people who from the non-healthcare sector, but honestly, sometimes within the healthcare sector, we need to do our own homework around looking at the 990 forms, those are publicly available, looking at who's on the committee or the board of the hospital, because typically someone on that board has investment expertise because they're helping the hospital manage its money, and thinking about who's on the real estate committee of the board and who's that person who has real estate expertise that's helping them think through their real estate investments, because those are the people that are going to help unlock those relationships to then start to do some of the symbiotic relationships or kind of systems that I was talking about in the keynote. I'm not going to talk too much because I definitely want to get to the questions portion of it, but I wanted to go a little bit deeper into those 3 healthcare dollars for my opening remarks.